thank you all for participating and being willing to learn more about borderline personality disorder, which is generally a not very popular topic amongst clinicians. Tara for BPD works to decrease the stigma and increase understanding of people with borderline personality disorder. Now, most of you probably look at the DSM to try to understand BPD, but we no longer look at the DSM as the holy grail of understanding borderline personality disorder. The researchers in Germany are way ahead of us, and they have defined borderline in this new view as a disorder of emotion dysregulation or emotion regulation, identity disturbance, cognition, and social interaction problems. Borderline personality disorder also has a hereditary factor of approximately 0.74%, which is from Torgerson in Norway. So this is a biologically based inherited disorder that runs havoc on the lives of the people with BPD and those who love them. Now, if you want to understand borderline personality disorder, you have to think about the evolution of the human brain over the thousands of years that we've been on the planet. And Walter Cannon identified the fight or flight response, which evolved in all living organisms. And in that concept, all stimuli are seen as a potential threat, because what was needed to survive in the forest primeval or in the jungle was the ability to figure out threats, to be able to feed oneself and to reproduce. And so our bodies are attuned to certain kinds of threats. And every animal, every mammal has every one of these fish, frogs, crocodiles, has a limbic system where we sense threats. And sensitivity and response to specific threats is the result of genes and learning. Now, in the brain, there is a part called the amygdala, which is a part of the brain that is there actively to sense threats. Now, we call this the threat protection system. The amygdala is part of the limbic system. It generates conscious feelings. It's a defensive circuit against threat. And part of this are emotions such as anger, anxiety, disgust, behaviors such as fight, flight, freeze, submission, and cognitive biases such as jumping to conclusions. And behavior is the end result of the threat protection system. It's a conscious feeling state, what you would probably call anxiety. All of this is governed through a part of the brain called the insula, which translates physiological responses circuits and gives you the sense of threat. Now, it's important to distinguish between behavioral responses elicited by threats and the changes in the body afterwards. Why is this important to you trying to learn about borderline personality disorder? Because people with borderline personality disorder are hypervigilant. They have a very high reactive threat protection system. So when we work with families, we remind them, you think of a periscope coming out of the ocean with a submarine underneath, scanning the environment to see what's going on. That's your borderline patient walking down the street, walking into a room, having dinner with their family. They are scanning for danger. Now, what's the problem with scanning for danger? They are, what would be the advantage of supersensitivity and hypervigilance? Why is this an inherited trait? Borderline personality disorder makes up 6% of the general population. Depression is 6.2% of the general population. That's a fact that's not very well known, but why would something like this be inherited to such a degree? So people with BPD have a superior sense of smell, sight, hearing, touch, danger. So what is the genetic advantage of this hypervigilance and supersensitivity? Well, they would sense danger before anybody else. They would be the greatest survivors. The problem is that in today's world, this super high sensitivity and sense of threat gets in their way because there's too much information coming at them all the time. I think that's why they get diagnosed with ADHD when they actually do not have ADHD. Now, the problem arises when you have this super sensitivity. How do we know that they're super sensitive? Ask a parent what the children will like. You're screaming at me, the food smells funny, the jacket is too itchy, I can't wear it, don't touch me. Families report this all the time. Now, what the problem is that people with BPD have a huge sense of aversion. So what is aversive arousal? It's a strong feeling of dislike, repugnance, antipathy, and it's a desire to avoid that which displeases, annoys, or offends them. So it's distaste, abhorrence, disgust. This is a core symptom of BPD, and it is the sudden and intense arousal that is experienced as being extremely aversive, and they can't assign it to a specific emotion. That's your affective changes that you would call emotion dysregulation or emotion regulation problems. They experience aversive feelings more frequently and escalate more rapidly than other people. They experience anxiety, anger, and grief 9 times more than normal control subjects. And they experience shame, whereas normal subjects do not. They generally experience shame more often than guilt. So, if you want to see what this looks like, here was a study done in 2001. So on the right-hand side, you see that the control subject experienced aversive arousal. The average was about 2. The borderline, the average was 7. So they're highly sensitive to emotional cues. They're super sensitive to criticism, judgment, blame, or rejection. They sense cues before other people. They're highly reactive, and they have a slow return to baseline. They're like walking powder kegs, ready to explode at any moment. So you've heard the story of the princess and the pea. That's your borderline person. And there's a quote from Anais Nin. She's a famous writer and diarist. I despise my own hypersensitiveness, which requires so much reassurance. It's certainly not normal to crave so much to be loved and understood. And here you see a little study that was done on startle. And when normal people were given neutral words, their response was about an 18, whereas the borderline had a higher response, about 24 or 25. When it came to unpleasant words, look at the difference between a normal control, which is the light blue, and the borderline patients who are up to almost 80. So that just saying about anything will set off a borderline, where it won't set off anybody else. Now, when you are in a stress situation and you're going to go into fight or flight, you release cortisol. So now let's look at how people with BPD, my theory is that they live drowning in cortisol. They're always ready to pounce. So the red line is the healthy control, the blue line is PTSD people, and the gray line is the people with BPD. So the first section, we see their baseline, where they begin from, and notice that the borderlines are starting way higher than the normal control. Then they're read a stressful script, something stressful. As the normal control is read the stressful script, he goes down, goes up a little bit, and levels off. The person with PTSD goes up a little bit, then goes down and levels off. Look at the borderline. As soon as they hear the script, they start going up, and when they're supposed to be recovering, they go up higher than anybody else, and then they go down, and then they go up again. So it is not possible in any way for them to calm down when they've been stressed. So what stresses them? So it's very important to realize that what stresses them is not mama's divorce or all of these very complicated issues that you come up with. What stresses people with borderline personality disorder are interpersonal issues in daily life. This is a study done by Paul Link. Notice that the bottom of the list is major life events. So they're not like that because this happened or that happened. They're like that. They go into these dysregulated moods because you looked at them cross-eyed, because you said a word that they felt was criticizing them. It's daily life. And that's why, even though they're in treatment sometimes, they don't do well in the outside world because daily life triggers them so much. So we call it ecological momentary assessment. When they come in and tell you what happened, you've always got to hear what the trigger was. When you hear what the trigger is, you'll know how to handle them. But you have to find out what was going on the other side. The other thing I have to tell you about BPD is that you can count on the fact that they're going to misinterpret whatever happens. So there's a new definition of emotions based on this brilliant researcher named Lisa Barrett. She's got several books out, and I suggest you look into it. She says that emotions are cognitively assembled states emerging from integration of information from your body, your memory, the sensation, and your perception. The physiological states that interfere between a trigger or stimuli, the behavior, and the physiological response. So they're experienced when you're unaware of them. They're implicit. They happen automatically. What we teach families and what you need to learn is to detect and process uncertain threats, which is what happens with people with BPD. When you experience a threat, you have to name it. People with BPD, that process happens in the insula in the brain. But unfortunately for people with BPD, they have very often a condition called alexithymia, which means when they come into your office and tell you how they're feeling, they really don't know how they're feeling. They can't name it. So they come in and they say, I feel depressed. So I have to remind you that depression is a vegetative state. It's inactivity. A person cannot be depressed, get a phone call, and get up and run out. So people with BPD can't name what they feel. So that leaves you with the job of trying to figure out what they're feeling through body language, through voice tone, through facial expressions, and through questioning them to get the gist of where they were and what just happened. So we call this whole system a neurotag. It's a pattern or map in the nervous system that links many systems into a conscious emotion experience. A pain or an emotion neurotag links systems into a conscious pain experience. So it's based on memory, on emotion, on a whole compendium of things. So we call this in BPD emotional blindness. They have abnormal interoception and alexithymia. So Antonia New, who is a very well-known researcher in the BPD field, she says people with BPD may really not have a clue about how they're feeling. The person may appear angry, will deny the anger. Their eyes may feel filled with tears, yet they will tell you that they're tired or they have a blocked tear duct. They have blunted subjective appraisal of their own emotional responses, plus heightened objectively measured emotional responses. What I'm trying to tell you is that self-report from a borderline is probably the most unreliable thing you can get. You have to interpret what they say in emotional terms and account for their perceptual bias. What they say may not be what they mean. In many treatments, we use validation. Validation is really a way to speak to their emotions. People with BPD really don't have a clue about what they're feeling. One of the things we do with class is we teach families to help them develop a scale. Oh, I'm angry. Well, how angry are you? Are you annoyed? Are you bothered? Are you irate? How furious are you? They really don't know how to grade out their own feelings. one of the jobs you can do is to help them to do this. Now, the way you can think about people with BPD is that it's like being with somebody who's colorblind. People perceive the same situation differently. You think you're sharing an experience with them, but they're not sharing it with you. So, for example, if you're riding down a highway and there's a red light, you want to stop at the light and the person's colorblind, they say, no, let's keep going. Well, the person with borderline is seeing the world in a completely different way than other people. You can think about this as the difference with perception and cognition. You seem to be sharing an experience, yet the experience is actually different for each person. So here you have this wonderful roast chicken. The husband says, oh, it's missing salt. The wife says, but it's too salty. The son says, it's just right. And the daughter says, it's too fatty. Who's right? Who's wrong? So you have to bear this in mind when you're dealing with somebody with BPD, because you start arguing with them and saying, no, it's just fine, then they feel misunderstood, not heard, and then they will escalate. So statements that to you are neutral or logical are often interpreted by people with BPD as critical, judgment, or blaming. And Thoreau said, it isn't what you look at that matters, it's what you see. And so with BPD, in my book, I have a section about sitting at the dinner table and saying to the person with BPD, pass the butter. Now, I have given this talk in countries all over the world, all over the United States, and invariably, the family members know what the BPD person would say. What do you think? I'm the maid? You think I'm too fat? You don't want me to eat? It's because they misinterpret the intention of what other people say. Now, perceptions are malleable. Reality is tricky, and brains make mistakes. We evolved to respond to threats and prioritize perception. So what happens with BPD in this little cartoon is my words came out fine. They were processed incorrectly by your brain. When you're talking to somebody with BPD, the way their brains work, there are 4 facts that you can count on all the time. They have rejection sensitivity. This happens in the anterior cingulate, which is Brodmann area number 25, for those of you who are interested in neurobiology, which is absolutely essential for you to know about. So here you see the normal controls are in blue and the borderlines are in red. Perceiving rejection. They are 5 times more likely to perceive rejection. And look at their ability to perceive rage. When a person with BPD walks into a room, they scan the faces to see who's rejecting them. I've had somebody with BPD tell me that she can't go on the subway because she can't look at the faces because they're all rejecting her. Secondly, in the same area of the brain, the anterior cingulate, they have a negative bias. No matter what happens, they preclude that it's going to end negatively. You know the expression, the cup is half full, the cup is half empty? For the person with BPD, the cup is always half empty. The normal control, when you see on 1.5, they look at social threats, look at the borderline people, how they overestimate. So you can be sure that whatever is going on, they're going to see it negatively and they're going to experience rejection. So social rejection, they feel excluded even if it's not intended, and they feel isolated, unacceptable, and misunderstood. So in the DSM-5, we say social exclusion. We call it the intense fear of abandonment. They experience social or rejection in family of origin or peer group, and this triggers a state of tension in them, and social inclusion leads to increased feelings of exclusion, inattention, and negative moods. So increased activity in the prefrontal cortex during social exclusion, and there's more activity in the neural alarm system. Now, one of the things you really have to know is that people with BPD misinterpret faces. And the face they misinterpret the most is neutral face. They have difficulty interpreting neutral faces. Why? Because they're ambiguous. So when you try to cope with BPD behavior in your office and you try to stay neutral, what you're telling the person with borderline is that you're angry with them, that you're angry, and probably you're angry with them. When you advise the family or friends when they're dealing with a person with BPD to stay neutral when they escalate, that's about the worst thing you can tell them. You have to match their emotion because they're going to misinterpret a neutral state. So this is very, very important. It's step one in resolving the problem with borderline. They can't deal with ambiguity. This is the work of Paul Ekman. The next thing that you can count on with people with BPD is that they're self-referential. So many times people are told that the person with BPD is also narcissistic. But I'm not so sure where that definition of narcissism comes in, because you have to take into account that people with BPD see everything in the world as being about them, especially when they're escalated or triggered, and especially when they're interacting with the people closest to them, what you would call their attachment people. So what happens is if it's raining, it's not raining on New York City or Los Angeles. It's raining on them. So there are specific areas in the brain devoted to information relating to the self. And that is, again, the anterior cingulate, Brodmann 25. And that's what we call self-referential processing. People with BPD process more information in the self-referential area of the brain than do normal controls. They personalize negative emotions, neutral faces are misinterpreted, and everybody else's reactions are personalized. So they're in a lot of trouble all the time. So now, how do we get to shame? What is shame, and why do we need to make shame visible and visceral? So shame results in them feeling disconnected, invisible, lonely, alone, isolated, living in a bubble, unheard, dismissed, unacceptable. And what is shame? Shame is a universal, debilitating core emotion. It's an intensely painful feeling or experience resulting in a person believing he is an outcast, unworthy of connection, unworthy of belonging, flawed, bad. Shame is a painful emotion arising from the consciousness of something dishonest, ridiculous, or indecorous in one's own conduct. It's highly negative, and the key word is it's painful. I've just come from the Society of Biological Psychiatry Conference and American Psychiatric Association. Very clearly stated that emotional pain and physical pain are experienced in the same way. So shame is experienced as pain, and it results in a disruption of ongoing behavior, confusion in thought, inability to speak. And it's an experiencing the self as unattractive, undesirable, worthless, inferior, defective, and unattractive social agent. Shame is an aversive feeling, and people with BPD feel it all the time. They have a sense of being exposed, and they try to hide. They try to avoid being found out, being exposed. What career do most people with borderline kind of navigate to? They're in the acting profession because they act to hide their real self. They lie to their therapist. They want you to like them. They want to escape or appease to relieve shame. What we found out recently with research from Jessica Peters is that when people with BPD feel shame, they ruminate, and it almost immediately turns to anger. And the anger will hide the shame. And because the ability to hide shame makes it more difficult to detect, it cuts them off from affiliation or soothing or connection with people who can make them feel better. And it's a way of them avoiding vulnerability, and it leads to fear, depression, and anxiety. And it's expressed differently by men and women. They're comparing the real self to the ideal self. They're perfectionistic. we recommend that people read Brene Brown's book, I Thought It Was Just Me, and watch her videotape. Shame is so aversive a feeling that we use it for torture. We use it to break down prisoners. Now, prisoners will experience shame even though they're not shame-prone. They don't consider themselves as bad or meriting prison. Now, you may wonder why I'm talking about shame when it isn't a topic that's generally researched or discussed. We at CARA run a national helpline, and people call and ask for referrals, so on. And we kept constantly getting calls from people with BPD asking for a support group. And I realized that there are support groups for gamblers and drinkers and hoarders and all sorts of things. I always say there's even a support group for hangnails, but there's no support group for borderline. Why? Because people are afraid to put borderlines together because they may commit suicide and you might be liable. So, being fearless in a way, I advertised a BPD group, Living with BPD, opened our doors, and 21 people with BPD walked in. It was rather shocking for me. And I just tried to give them a neurobiological understanding of what BPD is all about, for which they were very grateful. In that presentation, I showed this slide. And this is research that was done quite maybe 10, 15 years ago. And it was a study in which people were given little Palm Pilots, and they were buzzed a couple of times a day, and they wanted to know the emotional reactivity of the people with BPD and the normal controls. So we showed them that the people with BPD felt joy probably 50% less than the normal controls, and interest less. They felt anxiety more, anger more, and then look at the last three. The people with BPD felt grief, whereas the normal people did not, the normal control, whatever that may be. And then there was shame and disgust. And you'll notice that the normal controls did not say that they felt shame and disgust. When I showed this slide, the 21 people in the room stopped me dead in my tracks and said, that slide is wrong. So naively, I said, why is it wrong? And they said, because shame should be the highest one of all. So I was intrigued by that. The next day, I began my journey of researching shame. To my surprise, I found there was very, very little research on shame. And any research that there was from social psychologists. And I began looking into this. This is a study that was done in 2013. You have people with BPD, people with mood disorder, and they were given a reaction to shame. So you can see that the people with mood disorder, you can see the lower line, but shame induction, look at people with BPD, how high they go, and how long it lasts. So I then developed the hypothesis that shame may be the common denominator of BPD responses in most situations and experience. Shame is hating yourself and understanding why other people hate. So this is the way we think about it. When somebody tells us what triggered them, we try to interpret how that experience would be shame-inducing for somebody with BPD. And then we go right into, wow, that must have been so embarrassing. That must have been humiliating. If that happened to me, I would be mortified. We don't ask them if they experience shame. We sort of assume it. And there's an enormous relief when you can identify with their experience of shame. So now you also have to think about what is humiliation and what is embarrassment. So my boss pointed out my mistake in front of everyone. So you're a victim of unfairness. I don't deserve this. Shame is, I'm unworthy to work in this environment. Believe you deserve the reprimand. Embarrassment would be, I can't believe they saw me drop all of the folders all over the floor. It's fleeting, common, normal, happens to everyone. We can see it, people blush. But shame would be, I can't even carry my own folders. I can't do anything right. So embarrassment is a less intensive form of shame. But humiliation is incredibly painful, and you have to remember that. Now, you have to make the distinction between shame and guilt. The key part of shame and guilt is the sense of self. Guilt is I did something bad. It focuses on a particular misdeed. It's a private experience if you're conscious. It's healthy and adaptive. You can compare yourself to what you want to be, and you will strive to right the situation in a constructive way. It's pro-social. Okay, I broke a dish in your house, so the next day I try to replace the dish. I forgot your birthday, so I send you a bouquet of flowers the next day with an apology. But shame is I am bad. It's public exposure and disapproval. It's internalized. It's a self-evaluation of who you are. And when people feel shame, think of the gesture for shame. People cover their face, they hide themselves, and they therefore cut themselves off from connection with others, which would give them a dopamine spurt and make them feel a little better. Now, how do we associate shame with anxiety? On the right-hand side, you see the healthy control, where the bottom line is how they experience themselves with shame, and the top line is anxiety. With the people with BPD, the bottom line, the orange line, is how they see themselves with anxiety, but the top line is how they see themselves with shame. So what you're comparing is the bottom bar of the blue with the top bar of the orange. It's a very big difference. People with BPD live in shame. Well, in order to study this, what we did, we are a nonprofit educational organization. We're not a scientific research center, but we produced a survey put on the internet, and we have over 700 responses in which people with BPD described how it felt to feel shame. Shame is crippling, freezes me in my tracks, because I'm afraid that getting unstuck from my mess will make the mess, the shame, bigger. I'm stuck in being a flawed, unfixable person. I fear being found out. I feel like I don't deserve my life. I live in a bubble of shame. All I do and all I say, I question and fixate upon what people will think of me. I then convince myself I'm wrong, bad, worthless, and useless. We have 2 paragraphs written by each person times 700, and sometimes I can't read them. They make me cry. These people suffer with shame enormously. Now, we also asked on our survey whether they were shame-prone, and they said that they experienced shame all the time. It wasn't dependent on a situation. Being shame-prone means they're more prone to anger. Their anger is not letting off steam. It really results from rumination. Shame is significantly correlated with DDI scores, depression, obsessive-compulsive behaviors, paranoid ideation, and anxiety. It's an incredibly overlooked feeling. There's internal and external shame, implicit and explicit shame. It's emotionally crucial to one's social existence and self-identity. Explicit is a person's self-concept, consciously accessible, self-related cognition. Implicit is automatically self-related cognitions that aren't necessarily congruent with what's going on outside. External shame, they experience oneself as living in the minds of others. Now here I have a reference of Paul Gilbert, and Paul Gilbert has developed something called compassion-focused therapy. And compassion-focused therapy, which he developed on people with BPD, starts out that they were born with a tricky brain. They experience shame. It's not their fault. But now that they realize that, what are they going to do about it? It really talks about self-compassion, and it's a terrific therapy to learn to deal with BPD. Internal shame is linked to memory, to negative self-evaluation feelings. They carry negative memories with them all the time. Now, how do you recognize shame? You have nonverbal indicators of shame. So the head is down, the lips are drawn, they're slouched forward, less expressive behavior. Basically, shame will be directed towards the chest and the heart. So they will tell you very much about where they feel it. And language and shame. So they use their stupid, selfish, weak, inadequate. Pay attention to the language people use when talking about themselves. They'll look away or look down. They'll freeze. They'll change the subject. And shame is affected by alexithymia because they can't really explain it. Now, Donald Nathanson wrote a book, 1998, about shame and rumination. And he said that there was a compass of shame, that shame, people who experience shame will respond in one of four ways. They will withdraw, they will avoid, and avoid is a very, very important way people with BPD cope with things. They will attack themselves. Now remember, I said shame is experienced as pain. And when people with BPD are cutting themselves, they're trying to reduce their pain. It actually works because they produce endogenous opioids and will actually feel better. But the other thing that was amazing for me to learn was that when they experience shame, they attack others. And we usually describe people with BPD as being very angry. That anger very often can come from feeling shame. Now, in terms of rumination, people with BPD ruminate all the time. They repetitively think about the causes and situational factors and consequences of their negative emotional experience. They think about it, go over it over and over again. And they ruminate more intensely and frequently than individuals with other disorders. And their ruminations focus on distress relief, and it turns to anger. So it works something like this. They experience shame, they ruminate to anger, they get hostility, aggression, and they'll either attack themselves or attack others. So shame and memory. So to be vulnerable to external shame is to be sensitive to negative feelings and thoughts about yourself in the minds of other people. So verbal abuse and shaming inject negative meanings into the experience of the self. They have hypersensitivity and distorted cognition. You really have to try to parallel what a person with BPD tells you about an experience and an objective outsider or even a family member. Usually the stories don't match. They have same memory, act like trauma memory, and they can be intrusive. They lead to hyperarousal and efforts to avoid shame feelings. Shame memories are scenes in our minds, an interlocked set of body-based feelings and events that are sources of an emotional conditioning of negativity. It's a pretty sad place to be. And just for comic relief, senior shame. Grandma, don't tell me you study of seniors having sex. Shame and suicidality is a very, very important concept to think about. Shame proneness predicted suicide ideation in college students. Shame proneness in fifth graders predicted suicide attempts by young adults. When a person with BPD is talking about a recent, with shame about parasuicidal events, it will usually predict future parasuicidal events, which means self-injury. The combination of shame, self-hatred, self-invalidation leads to self-punishment, says Marshall Linehan. In veterans, shame was correlated with suicide. Individuals describing shame-inducing events are less likely to express empathy for others in a situation. When they are in a shame state, their whole fight or flight system of their brain is in high intensity. And when that system is very high, it turns off the prefrontal cortex, which is where you have executive function, evaluation, and understanding the situation. So experience of shame is related to difficulty in describing events, and they're less likely to feel empathy at those times. The references that I've listed here, most of these references are references from social psychology. People with BPD are not looking for unconditional love. Because they're so shame-prone, what they are looking for is unconditional acceptance. And that's why a lot of these treatments bias towards Buddhist concepts. And that's why Marshall Linehan in DBT went towards meditation and Buddhism. But what we work with families is to accept the person as they are in the moment. And shame makes therapy most difficult. So what we strive for at Tara is relationship repair. We focus on specific actions for relationship repair. We try to be able to mentalize what happens to them in social situations and to identify the actions or the emotions to repair. We try to be non-judgmental, and we try to be compassionate, and we try very much to stop self-blaming. The family can very much help decrease shame response because they happen within the family. We can't protect a child from shame. Internalizing shame, it results in them acting as if they're apparent competence, which ties shame. Shame leads to suicide 50 times more likely when they have high shame. According to John Gunderson, treatment focusing on familial, social, and vocational training decreases suicidal behavior. What we do in our current treatment is we reduce symptoms, but we don't change this long-term concept of shame. Families can help to decrease shame responses with validation, with normalizing. Oh, anyone would be embarrassed if that happened to them. With mentalizing, with checking the facts. Well, why do you think he wasn't talking to you? Did you think he saw you? Did he have his glasses on? And changing language. My boyfriend dumped me. Oh, you mean you and your boyfriend broke up? And reminding the people of positive memories and self-disclosing when they've been in situations that would be equally negative or upsetting. Shame may be the emotion that makes therapy most difficult. Coping with in-session feelings, whether to drop out or not. Shame functions to hide problematic behavior, and they can't solve their problems because it's too aversive to focus on shame. What we need to do is reduce rumination, improve reflective functioning, clarifying what the problems are, and helping people to understand moment-to-moment states of mind and to change some of these horrible self-labels that they have. So in conclusion, BPD is a complex disorder of difficulties in response to perceived threats and misperception of interpersonal interactions and intentions of others. These problems can be correlated to specific brain regions and connections, all about circuits between these regions, and the individuals seem to be born with a proclivity to high sensitivity, high threat perception, high reactions to stress, and dysregulations in the opioid system. We need more research to learn how BPD affects memory and sleep, interpretation of language, pain processing, and interpersonal perception. My book is 400 pages. It's peer-reviewed, Overcoming Borderline Personality Disorder, A Family Guide to Healing and Change. And I truly hope this presentation helps you to understand BPD and see them in a kinder way with compassion, because these folks are suffering. The miracle is that more of them don't commit suicide. I also refer you to the work of Thomas Joyner, who is looking at the difference between depressive suicides and these impulsive suicides that generally come from these kind of same showers, same storms that happen to people with BPD. Those kind of suicides do not need hospitalization, because by the time you get to the hospital, the whole event is over. So, and hospitalizing them will also increase shame. So I'll be happy to take any questions, and I hope that this was helpful to everyone. And please, if you need us, you can reach us at SARA4BPD@gmail. We have a website. We run classes for families, and we will be running some classes at mentalization and on shame in New York City that professionals can attend. And thank you for your attention.
Thanks, Ms. Porr. That was a great presentation, I must say. Now we are going to start our question-answer round. We have few questions from the participants. First question is from Elizabeth Ford. She wanna ask, would you suggest, based on your research, that BPD should be reclassified and no longer be an Axis 2 disorder? Is it truly a personality disorder?
BPD was reclassified in the DSM-5. There is no longer an Axis 2. It's considered a personality disorder, and there is no more Axis 2 for personality disorders. So it's already been done. It's a done deal. I will say that it is a very distinctive disorder and is very different in its physiological responses than other disorders. For example, a person with BPD and a normal control are put in a situation where they experience pain. The person with BPD will tell you that the pain is so extreme it's awful. The normal control will say, oh, well, it's a 2 or a 3. And when you look at the physiological responses, the person with borderline has the least response and yet will verbally describe it as more intense than the normal control. And this kind of mismatch between the physiological and the cognitive goes along with many different biological systems. I hope that answers your question, but you check DSM-5, it has already been changed.
Thank you so much. Moving on to the next question from Sarah Morano. What is the best treatment options for teenage girls clinically diagnosed with BPD? We are desperate to find treatments that work for my 14-year daughter. You are literally describing her in every slide, and we are so desperate because her therapy is not helping, and she is now on ADHD meds and Prozac. Please help.
Well, the ADHD meds and the Prozac probably not helping. They may help for a little while, but those meds really don't work. CBT is the treatment that's most available. And CBT is a treatment in which there are 4 skill modules, and it teaches them how to tolerate the stress, how to bring themselves down when their emotions go up. Unfortunately, it does not affect this core behavior of shame, this core feeling of shame. Mentalization is a wonderful treatment. However, it's barely available in the United States. It's done at McLean Hospital, at Menninger, at UCLA Harbor, in a few places across the country. The person can call us for a referral. The other treatment, compassion-focused therapy, is excellent. Again, it's not very available. The Europeans treat borderline in a completely different way than we do. They do 3 months of inpatient treatment with all kinds of treatments at the same time, not particularly with medications because they generally don't work. And we've been doing this for 25 years. Borderline needs enormous advocacy. We get very little money for treatment and research. And DBT is really the only treatment that you can find in some communities. Most places have wait lists. That's why we work so hard with families. We work with the families in an effort to get them to be able to bring down escalations in the moment and to increase trust with the person with BPD. We try to create at least a little island of safety for the person with BPD. You can check our website. We do family programs. We have a workshop coming up June 8th, 9th, and 10th. And with the techniques that we use that are in my book. But it's a very, very sad picture for people with BPD. I think of it the way people with AIDS experience life and treatment about 25 years ago.
Thank you. Moving on to the next question. What do you find is the best way to help people with BPD recover from addictions?
Well, having just spent 8 days at 2 very intense conferences, I have to tell you that it looks to me like the future for people with BPD and addiction is Suboxone or buprenorphine. It seems to be the most helpful. And the good news is they've recently developed an injection of buprenorphine that can last for a month. So buprenorphine is like a synthetic heroin that they use to get people off heroin. But I think that there's a study that was done in Israel where they used very low doses of buprenorphine on people with BPD who were suicidal and self-injuring. And those people stopped feeling this negative feeling all the time and felt much better. So many sessions at the last 2 conferences I attended talked about using buprenorphine in treatment. Putting people in residential treatment to get rid of addiction, I'm sorry to say, it's pretty useless. It doesn't really help them because you haven't solved the problem that created the addiction in the first place. And the other major problem is if you put them in residential treatment and they're clean, they come out and then they use again, there's fentanyl in the heroin that they get on the street. And it's so deadly that we were told that people die with a needle in their arm. That's your opiate epidemic that's going on nowadays. People die with a needle in their arm because the fentanyl kills them that fast. So I don't know what treatment there is. It's a major national catastrophe. The other point is marijuana. The marijuana that's available today is probably 10 times stronger than when I was young and experimented with things. And marijuana, as I've been observing, leads to a lot of people with BPD going into a room and hibernating and smoking a lot of marijuana. And the danger with that is it's an absolute example of avoidance. And what they're doing then is depriving themselves of the contact with other people, the connection with people that would give them that dopamine fix and make them feel less isolated. So we don't have an answer for what's the best treatment. I think the government, the National Institute of Drug Abuse and Alcohol, are searching for ways. And as of right now, I can tell you so far, it seems like the best direction is buprenorphine.
Thank you so much. Moving to the next question from Katie Smith. You mentioned earlier that remaining calm and when a person with BPD escalates is the worst thing a loved one can do. What would you suggest as a better alternative?
Thank you for that wonderful question. Okay, when somebody with BPD comes at you and they're screaming, "I'm so angry with you," the answer has to be, "Wow, you're so angry with me. What happened?" If you turn around and you go, "Oh, you're so angry. What's going on?" the person feels completely unhurt. The same works in reverse. If they're very low and, "I'm really sad," don't be ridiculous. Snap out of it. That's not going to help either. So what we teach is to match voice tones, to bring yourself to just about a little bit below their anger or a little bit above their very low voice. Now, considering that we in America are generally conflict aversive, and you take a bunch of families and tell them to match voice tones, this is so anti-intuitive. They think that what is wrong with this person telling us to do this? But I have to tell you, it works. So you have to match voice tones because that way you're reflecting back their emotion and you're indicating that you actually hear them. So try it with a friend. A friend comes at you with something upsetting and you answer in a very low tone. They're not going to feel like you hear them.
Thank you so much. Moving on to the next question from Michelle. What would you recommend for BPD patients with abusive family and abusive family histories?
Well, first of all, I'd want to be sure that there was abusive family history because there's always a mismatch between how people with BPD see things and how the actual event is taking place. I think that our aim at Tara is relationship repair. When the family stops paying the bill, or the borderline can't pay the bill, or when the borderline person drops out of therapy, usually it's the family that comes through and is there for them. So the point is the family just does not understand what's going on, and nobody really explains it to them. And they get a tremendous amount of very bad information on the internet. We get families to come in and tell us that the therapist told them to stay neutral, to put up boundaries. For a person with borderline, that's abusive. This is a very, very important topic that needs clarification. I'm sure there are many families that are abusive, but borderline is not caused by abuse. It starts out with a hereditary proclivity towards this disorder. So I don't know how to answer that other than do your research, make sure it's going on, and in any possible way try to work with the family because you can count on them at some level. If the family is terribly abusive, then you have Child Protective Services is going to do something, or the person has to go on their own. The biggest problem of all for me and for our organization is how to help children who have a parent with borderline who are experiencing these changes in mood all the time and these expressions of anger. We have a program for siblings. We have a program for spouses. We work with families. But the children of people with BPD bring us to our knees. Those are the hardest people to help.
Thank you so much. Moving on to the next question, that will be the last question of the session. This is from Erika. In your opinion, what role does therapeutic communication play in assisting persons with BPD in light of their unique self-view and hidden issues with shame? It seems that specialized methods of communication might be beneficial. Are there any resources to assist families and professionals to improve communication for better outcomes?
Well, that's all that we do at Tara. That's what my book is about, and that's the essence of treatment for borderline, is to teach them how to communicate. There's an incredible problem with BPD. They do not understand cause and effect. So when they say something abusive or insulting to a person, they don't understand why the person gets angry with them because they feel self-righteous in the moment. I think that because they experience so much shame and they see themselves as so disempowered, they don't realize that they can hurt somebody else. One of the things we do is we use the relationship to help them. So we teach communication skills within relationships, such as, I can see you're really upset. It must have been very hurtful when Mary canceled her date with you. At the same time, when you scream at me, it makes me feel like I don't count and like you don't care about me, and then I don't want to help you. What do you think we can do about this? In doing something like that, you're showing the person that they have an effect on you because they truly don't realize it. Eric Kandel got the Nobel Prize for showing that the brain can create new circuits. I think that with BPD, you have to train them and teach them as if they were children. We see them as emotionally about 12 years old. You have to teach them emotional skills. You have to teach them interpersonal skills. You have to teach them how to repair relationships. And unfortunately, sometimes they have to be consequences. So social skills teaching is crucial and is taught within probably every treatment.
We've got one more question. That is the last question of the session from Angela. With shame, would you consider that with BPD, there may be an unconscious source of shame that cannot be visible or visceral?
I don't understand the question.
Okay, I repeat. With shame, would you consider that with BPD, there may be an unconscious source of shame that cannot be visible?
In my research on shame, I'm trying to find out when the shame develops in a child and where in the brain it's located. And there's no definite research there. I was looking at Erickson, which was from the 50s. don't quite know. Erickson talks about Freud and the anal state. I think shame is something that develops in all children as a social mechanism going back to evolution on how societies were created. But, Marshall Linehan calls her treatment dialectic behavior therapy. The term dialectic means that two concepts can exist at the same time. I did something bad, but I'm a good person. That's dialectic. I've heard people with BPD say that they can't understand that concept. They cannot understand how two things can exist at the same time. Shame, going to guilt, requires that you be able to have the dialectic ability to see that you did a bad thing, but you're not a bad person. I think this is just my soapbox theory. I think somewhere people with BPD don't get to that developmental stage, not only about shame and guilt, but about all things. That's where you get your black-white thinking. They don't seem to be able to integrate two different points of view. I hope that answers the question. It's a question.
All right. Thank you so much. And considering the time frame in mind, we need to end this session right here. Thank you, Ms. Porr, for being most astonishing webinar speaker for Sovereign Health Group. Thank you, attendees, for your participation and joining us today. If you have any further questions, please feel free to send them at webinar@sovhealth.com.